Hey everybody, and welcome back to the channel, The Whiteboard Doctor. We appreciate you checking out the video today. Really interesting topic, and that topic is hyperglycemic or high glucose crises, specifically diabetic ketoacidosis or DKA and hyperosmolar hyperglycemic state or HHS. This video is intended primarily for those in the medical profession, whether it be students, trainees, physicians, PAs, NPs, nurses, respiratory therapists, EMTs, paramedics, nurse anesthetists, etc., etc., etc. But also for those interested in having a better understanding of diseases, specifically if you have diabetes or know someone who has diabetes. This may be an interesting video for you as well, so definitely stick around and check it out. Quick reminder, we'd love for you to subscribe. It helps us, get to know you, see how the channel's doing, and start to mold things to our subscribers and the things they're interested in hearing about. Also hit the bell button, all that good stuff, and definitely check out the other videos on our channel as well if this video pertains to you. No further ado, quick break for the introduction. We'll see you right back. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer, none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So with no further ado, diabetic ketoacidosis and hyperosmolar hyperglycemic states. So just starting, we're going to state, these conditions affect those with diabetes. And as many of you know, diabetes is a disease that causes glucose metabolism dysfunction, specifically in regards to insulin. So glucose metabolism is primarily driven by insulin. Insulin is a molecule our body secretes from the pancreas, particularly beta islet cells in the pancreas. And insulin is kind of the signaling molecule that metabolizes glucose or sugars. And we need glucose metabolism to survive, to live. A large part of the energy our body produces is secondary to glucose metabolism. So without insulin, we can't metabolize glucose, and without glucose, we really can't produce the energy we need. And that's where diabetes comes in. Now, there's two different types of diabetes, and we're not going to dive into this. There's actually multiple different types of diabetes, but the two people are most familiar with are type 1 and type 2. And the, kind of running, kind of general understanding of this, although it is inaccurate or doesn't tell the full story at least, is type 1 diabetes is lack of insulin. You don't produce insulin. And type 2 diabetes is resistance to insulin, or your tissues no longer respond to insulin the same way someone else's does. This is totally short-selling these topics. There are actually multiple different types of diabetes beyond type 1 and type 2, and lack of insulin and insulin resistance also don't tell the full story. So if you're interested in us doing a video on those, definitely let us know in the comments, but we're not going to dive into that within this lecture just because we got a lot to cover already. So when diabetes goes awry, let's say someone with diabetes is eating more sugary foods than they're supposed to or typically do, or they're not taking their insulin, or they get sick, a precipitating factor occurs, right? And this could be med non-compliance. This could be illness. This could be diet change, stress. All those things, all those precipitating factors lead to a lot of downstream effects that those without diabetes don't necessarily have to deal with. And that is because the patient with diabetes, their body reacts differently to glucose, right? So when there's a precipitating factor, such as medication non-compliance, we're not taking our insulin, our body with diabetes starts to act as if it is not having enough glucose in the body, right? Because insulin is really the driving signaler. So without insulin, we're not taking our insulin, let's say, that's our precipitating factor. Our body goes, wait, we don't have any glucose in our body. And that's not true, right? You have glucose in your body. You just don't have insulin to signal to your body that you have glucose. But what starts to happen is our body starts to increase these counter-regulatory hormones that do everything they can to either produce more glucose, even though we already have glucose, or decrease the utilization of glucose by certain tissues. And all this starts to do is it starts to increase the glucose circulating in our body. But there's still no insulin, so our body still is not recognizing that there is this glucose. And what happens here is our body starts to secrete things like glucagon, right, to increase glucose circulating, catecholamines, cortisol, which is a hormone, growth hormone. And all these things trigger these cascades that then increase circulating glucose. So gluconeogenesis, we actually start to produce more glucose and put it into circulation. So that increases glucose in circulation. Glucogenolysis, proteolysis, where we start breaking down our proteins into increased glucose. And then we start having our peripheral tissues stop using glucose because, again, our body thinks there isn't glucose. So it wants our brain to get glucose, our heart to get glucose, and it says, okay, I need the most important tissues in the body to have as much glucose as we have left. So I'm going to stop having our muscles use glucose and other peripheral tissues, right? And all this is increasing the amount of glucose we have circulating in our body. But remember, we already have enough glucose. Let's just say, let's say that someone had, I don't know, their glucose was 300 in American units. All right, that's high. Our body, though, doesn't have insulin, so it says, I don't have 300 circulating glucose, so I'm going to do gluconeogenesis, we're going to do glycogenolysis, proteolysis, and we're going to keep producing more and more glucose. Now the circulating glucose in the body is 600. It's 900. It is increasing more and more, but without insulin, our body still cannot recognize that there is glucose circulating. So what happens then is all these things lead to hyperglycemia, worsening and worsening hyperglycemia. And when that starts to happen, our body starts to get really dehydrated because our kidneys can only filter out so much glucose. You'll see varying things, but they say kind of, that's too thick. Say our body can reabsorb kind of 200 to 300. I forget the units for glucose. I think it's like something per deciliter, 200 to 300. So when the glucose gets above 300, our body starts to urinate out glucose. But glucose is it's osmotic, so it draws water with us. So I'm just gonna draw, a terrible nephron. So that's glomerulus. There's the proximal tubule, loop ahead and lay into the distal convoluted tubule. Right, so what happens is we usually, if glucose gets in the nephron, and then this goes into the urine, just if anyone didn't know, so this is kind of the part of the kidney goes into the urine. So usually our body will reabsorb all the glucose back into the bloodstream. But when the glucose gets really high, it starts sticking around in the nephron, and then it starts drawing water with it because it's osmotic, so it starts drawing water in. And then we pee out all of this water and glucose, causing osmotic diuresis, and it dehydrates us, right? Because usually our body is reabsorbing glucose, reabsorbing most of the water back into the bloodstream, which is why when we pee, our pee, if we're dehydrated, it's very, very dark. If we're really hydrated, it's very light. But the glucose that sticks around in the kidney, in the nephron, pulls water with it, so we pee out all that glucose and water, so we're not reabsorbing the water, and it dehydrates us, so we get osmotic diuresis. And that causes a lot of the big issues that we see in hyperglycemic crisis, whether it's diabetic ketoacidosis or HHS, which we'll talk about. And that's hypovolemia, right? We get dehydrated. Electrolyte derangements, because we're so dehydrated, we're urinating out so much fluid that we start to get electrolyte abnormalities. And we're starting to lose a bunch of free water in our body, free water loss, right? Because we're urinating it out. So that hyperglycemia that our body is not even believing is there because we don't have insulin to signal to the body that you actually do have plenty of glucose is leading to osmotic diuresis and a lot of downstream effects, dehydration, electrolyte derangements, and free water losses. Now, whether we develop diabetic ketoacidosis or HHS, hyperosmolar hyperglycemic state, depends a little bit on if we have any glucose circulating. And I'm going to simplify this. It's very complex. But in diabetic ketoacidosis, we don't, circle with a cross through it, we don't have any insulin circulating. So it's a lack of insulin. In HHS, we have some insulin, but we don't have enough insulin circulating. And I want you to think for a second about what that might mean, right? If we don't have any insulin at all, we already talked about insulin is what tells our body that we have enough glucose in the body. So if we have no insulin at all, our body goes into pure panic mode. And it says, we have no glucose. I need another way to make energy, right? Because glucose is what produces most of the energy. So if you don't have insulin, so your body is not able to use glucose, your body is not able to tell it has glucose, it says, I need another way to make energy. So you get this absolute insulin deficiency. And to make energy, your body starts to use fats, lipolysis, lysing of fats. That creates free fatty acids that are metabolized into energy, but it leads to ketosis or ketone bodies. Ketone bodies are these negatively charged acidotic bodies. And that's why you get acidosis in diabetic ketoacidosis, right? Ketoacidosis. You make ketone bodies and get acidosis. And that happens because, again, your body has no insulin, so it is not able to tell there's glucose, which means it doesn't think there's glucose around, which means it can't use the glucose to make energy, which means it then finds another energy source, fats. It starts to metabolize the fats into energy and makes all these really acidic ketone bodies, leading to ketoacidosis. And that acidosis in DKA is what can make you very, very, very sick. HHS, on the other hand, is not enough insulin. It's a relative insulin deficiency. So your body has a little bit of insulin, right? It has a little bit of insulin. It still says, I only have a little bit of insulin, so I can't really tell if I have enough glucose in the body. So I'm still ramping up glucose production. I'm causing hyperglycemia. I'm urinating out all this glucose and water. I'm getting dehydrated, but I still have a little bit of insulin. So I don't need to do this. I don't need to make energy through fat metabolism. I can still make energy with glucose. So I can still metabolize some glucose to make energy, which is why you don't get this acidosis in HHS, right? You get that acidosis in DKA, but not HHS, no acidosis. Because you're not making ketone bodies, because you're using what little insulin you have to metabolize glucose into energy. But because of that, you never get acidotic. So this progresses over a longer period of time, and you get severe hyperglycemia. Because in DKA, the acidosis makes you so sick that you can't be in DKA for long enough to get the severe hyperglycemia that you can in HHS. Because in HHS, you don't get acidotic. So HHS usually can progress over weeks. And your glucoses can get really high, in the 1,000 or 2,000 range. Whereas DKA usually progresses over days. And your glucose is high, but, it's usually, 300 to 600 range. These are just rough estimates, right? So it does not get as high as it does in HHS because you get so acidotic in DKA and you get so sick that you would die before your glucose could get to 2,000. Whereas in HHS, you don't get acidotic, so you just get more and more and more and more dehydrated while that glucose gets higher, 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 until you get so dehydrated and you have so much glucose in your blood that you get some downstream negative effects, which we'll talk about. So that's the pathophysiology of DKA and HHS. That's the difference between the two. Definitely complicated, definitely complex. That's why most people say DKA is mostly type 1 diabetes because it's this insulin deficiency, although this is not true. You can get DKA with type 2 diabetes, whereas most people say HHS is type 2 diabetes because it's a relative insulin deficiency. But again, that's not necessarily true. All right, so then what symptoms do we see with these? Well, the symptoms are a result of the pathophysiology, which we talked about, right? So we mentioned up here that you get osmotic diuresis, right? Your glucose gets so high that you start to pee out glucose because you can't reabsorb it all, and water follows, so you pee out glucose and water. So you get polyuria and polydipsia. Polyuria is increased urination, and polydipsia is increased thirst because you're trying to replenish all the water that you're urinating out. And this happens in a large percentage of patients, maybe as much as 98% that have DKA. You get weight loss from water loss. You get really fatigued. You can get short of breath. This is usually to compensate for the acidosis, right? So we said in DKA, you get really acidotic because those ketone bodies being produced. So you start breathing harder to breathe off CO2 to try to make the blood less acidotic. A lot of people get vomiting, abdominal pain. And as we mentioned, DKA develops more rapidly than HHS, right? DKA develops over hours to days. So the most common symptom is polyuria, polydipsia, as much as 98% of patients. 81% have weight loss, 62% fatigue, 57% dyspnea, 47% vomiting, 32% abdominal pain. HHS is fairly similar. So you get similar symptomatology in HHS as you do to DKA. But in HHS, you have a much more likely to have neurologic symptoms, right? It could be confusion, it could be drowsiness, hallucinations, but progressing all the way to like obtundation where you're just totally unresponsive. And as we said, it develops more slowly, days to weeks. So these are primary symptoms of the two, and they're related, like we talked about, to the pathophysiology, which is interesting, right? If you understand that pathophysiology, you can really start to understand the symptoms too. All right, so then the last part of this lecture is going to be general management principles. I want to emphasize these are the principles. Certainly these are not medical recommendations. Definitely, read about this and all that kind of stuff, but these are general principles based on our opinion. So in DKA principles over here. How do you manage DKA? Well, the management is related, again, to the pathophysiology. Right, you get that osmotic diuresis, you're peeing out all that glucose and water, so you have to replenish fluids. You get electrolyte derangements because of the osmotic diuresis and the insulin, lack of insulin, so you have to replenish certain electrolytes. And then your body doesn't have insulin, which is why it is going into panic mode, increasing the circulating glucose, going into ketone production to try to produce energy. So what do you have to do? You have to give back insulin. Now, the details of this, again, this is just kind of general management principles. Certainly not recommending you do this in the clinical arena. There's lots of variability here. But in terms of fluids, right, we said you get osmotic diuresis, so you get significant volume losses. People estimate that you lose almost 10 to 15% of your body weight, right? We said weight loss in 81% of patients with DKA because of fluid loss. And this can equate to about 2 to 6 liters of intravenous fluids that a patient is down. Now, you don't tend to give 2 to 6 liters right away. There's a lot more caveat to this. So again, don't just go do that. But this is kind of a general thought principle. With electrolytes, you want to target a high normal potassium, phosphate, and magnesium. The potassium and phosphate actually go intracellular with insulin administration, right? So you have a cell, you have the intracellular space, and then you have the extracellular space. And you have all these electrolytes in both places. And there's these transporters, right? When you give insulin, potassium and phosphate get transported intracellularly, right? So when you start to give the insulin for the management of DKA, potassium and phosphate are going to go into the cell, which is why you want to target high normal levels of potassium and phosphate to start with, because you know when you start to give insulin that potassium and phosphate circulating in the blood vessels is going to get lower because all that potassium and phosphate is getting shifted into the cell. All right, after you replete the electrolytes, you can start insulin. Again, general management principles. And starting the insulin is what is going to shift a patient back towards glucose metabolism, right? Because we said without insulin, the body starts to metabolize fats, and that produces ketones, which are acidic, and the acidosis is what can kill you in DKA, among other things. But giving insulin back, once you replenish the electrolytes and give some fluids and all that kind of stuff, is what will shift them out of fat metabolism, because once you have insulin, the insulin tells the body, hey, wait, you have all this glucose that you can use for energy production. Stop doing this. Stop metabolizing fats. And you want to watch the serum osms, cerebral edema, and things, which again is outside the discussion in this video. Okay, so HHS principles, very similar to DKA, right? We have fluids, electrolytes, insulin. The difference here, though, is that you actually tend to be more dehydrated in HHS. Why does that make sense? Well, we said HHS develops over months. Sorry, that's too long. Weeks. And the primary thing with HHS is those glucoses are so high, right? And with those glucoses so high, you have even more osmotic diuresis. So you're even more dehydrated than those with DKA. Some estimate that you can be as much as 6 to 10 liters dehydrated. All right, significant volume losses. The osmolarity of the blood is very important. For those who want to go down a rabbit hole, we'll do it quick. Let's see if I can remember the equation off the top of my head. So serum osms, the osmolarity of the blood, is equivalent to a proportion of glucose plus sodium plus BUN. And I think if we did this in the true math sense, I think it's 2 times the sodium plus the glucose, oh boy, divided by 18 plus the BUN divided by 2.8. And someone please correct me if I'm wrong. That was off the top of my head. I think that's right though. So this is the serum osms. And as, again, outside of this lecture, but serum osms, intracellular space, extracellular space, determines how water shifts. If the serum osms are much higher outside the cell, water will shift outside the cell towards the higher serum osms. So you want to really manage those serum osms, which if you're interested in us talking about that, definitely let us know. We could put it in another lecture. This is just kind of an introduction. Electrolytes, same thing as in DKA, high normal levels of potassium, phosphate, and magnesium. That potassium phosphate will shift intracellularly with insulin administration. Insulin in HHS is not as important. You don't want to start this as quickly as you would in DKA, because remember, in HHS, you don't have ketone production. This whole fatty acid metabolism to ketones, which causes acidosis in DKA, you don't have that because your body still has some insulin it's responding to. So you're still using glucose for energy production in HHS. You just don't have enough insulin. So the real thing in HHS is really electrolytes and fluids. And then at some point you will start some insulin, but this is an afterthought. This is much, much later. And then your serum osms in HHS tend to be much, much higher, right? Because we said serum osms equals glucose divided by 18. So in DKA, if your glucose is 500, that's a lot different than if your glucose is 2,000 in HHS, right? To glucose at 2,000, these serum osms are going to be much, much higher. So as such, you want to pay a lot of attention to the serum osms in HHS. And if this is an interesting lecture to people, we certainly can dive into some of the more advanced management of these two. That's all we have for you today, though. Kind of introduction to hyperglycemic crises, DKA, HHS. Hope that was interesting, helpful, intellectually stimulating. Definitely let us know what thoughts, comments, questions you have down below. Check out the other videos, subscribe, hit the bell button, all that good stuff. We appreciate y'all. Stay well, keep learning, and we'll see you next time.